Hello friends, today we are going to discuss about diabetic ketoacidosis. Diabetic ketoacidosis is the serious and potentially life-threatening complication of diabetes mellitus. It represents the state of insulin deficiency with concurrent elevation of counter-regulatory hormone. The annual incidence ranges from 4.6 to 8 cases per 1000 diabetic patient, and DK carries mortality rate of 2% to 10%. DK occurs more commonly in patients who have type 1 diabetes as compared with patients who have type 2 diabetes. So pathophysiology of the decay is diabetic ketoacidosis is complex disorder, metabolic state which is characterized by the hyperglycemia, ketonemia or acidosis. Decay usually occurs as a consequence of absolute or relative insulin deficiency that is accompanied by increase in counter-regulatory hormone. This type of hormonal imbalance enhances the hepatic gluconeogenesis and glucogenolysis, resulting in severe hyperglycemia. Enhanced lipolysis increases the serum free fatty acid that are then metabolized as an alternative energy source in the process of ketogenesis. This results in accumulation of large quantities of ketone bodies and subsequent metabolic acidosis. Ketones include acetone, 3-beta hydroxybutyrate, and acetoacetate. The prominent ketone in the blood is 3-beta hydroxybutyrate. There are several mechanisms responsible for the fluid depletion in the decay. These include osmotic diuresis due to hyperglycemia, vomiting commonly associated with the decay, and eventually inability to take in fluid due to diminished level of consciousness. Electrolyte shift and the depletion are in part related to the osmotic diuresis. Hyperkalemia, hypokalemia need particular attention. So the precipitating factors are infection, urinary tract infection, pneumonia, medical non-compliance, inadequate insulin dosing, and new onset diabetes mellitus. The other causes are acute myocardial infarction, stroke, pancreatitis, trauma, pregnancy, surgery, alcohol, and abuse medications like corticosteroid, thiazide, phenytoin, beta blocker, and dopamine. Clinical representation is metabolic abnormality associated with decay develop rapidly and usually within 24 hours. However, signs and symptoms of poorly diabetic control may precede decay by several days. Patients often present with polyuria, polydipsia, weakness, fatigue, and altered sensory. Abdominal pain, nausea, vomiting are common features in decay that resolves with correction of acidosis. Persistence of these features after resolution of decay may signify the presence of intra-abdominal process. On physical examination, signs of hypovolemia are often present, including dry mucous membrane, decreased skin turgor, tachycardia, and hypotension. Additionally, patient may have fruity odor to their breath as the consequences of acetone release. Deep and labored breathing or Kussmaul's respiration may also be observed under attempt to correct the metabolic acidosis with compensatory respiratory alkalosis. However, the excess acid cannot be expanded. Mental status can range from the intact sensorium to the diabetic coma. Then about lab finding, the initial lab evaluation in the decay include measurement of serum glucose, electrolyte, blood urea nitrogen, creatinine, urine analysis, testing for ketone in the urine and serum, assessment of serum osmolality, and arterial blood gas values. Further testing may be done to identify potential infections or myocardial infarction as a decay precipitate. These tests may include complete blood count with differential, urine and blood culture, cardiac enzymes, ECG, and imaging studies such as chest radiographs. The hallmark lab finding in the decay are hyperglycemia, serum glucose more than 250, ketosis, that is positive serum or urine ketones, acidosis, that is blood pH of less than 7.3, and serum bicarbonate less than 80. So decay can be classified into three categories like mild decay, moderate decay, and severe decay. Mild decay includes the arterial pH of 7.25 to 7.3, serum bicarb level of 15 to 18, and then gap of more than 10, and mental status, the patient will be usually alert. Then in moderate decay, the arterial pH will be 7.27 less than 7.25. Serum bicarbonate levels are 10 to less than 15. A anion gap of more than 12. Mental status will be drowsy. Severe decay is arterial pH of less than 7, bicarbonate less than 10, anion gap more than 12, and the patient will be in stupor, either stupor or coma. The presence of high anion gap metabolic acidosis, decreased level of serum sodium, and elevated potassium level are common features in the decay. Low or normal or low level of potassium typically indicate total body potassium deficiency and require vigilant monitoring and repletion. In comparison with the high serum osmolality seen in hyperosmolar hyperglycemic state, serum osmolality is variable in the decay. Amylase elevation occur in 21% to 79% of decay cases and often from non-pancreatic source. Lipase can be elevated in decay but can also be the marker of pancreatitis. Therefore, clinical judgment and the follow-up of patient's clinical status as decay is treated as are imperative to the differentiate between the two processes. Mild leukocytosis ranging from 10,000 to 15,000 may be present due to dehydration, stress, and demargination of the leukocyte. A higher white blood cell count is often indicative of the infection. Now, about the management. The presence of one or more of the following may indicate severe decay. That is blood ketone level over 6, bicarb level of less than 5, venous and arterial pH of below 7, hypokalemia on admission, GCS less than 12 or above ABPO scale, oxygen saturation below 92% on room air, systolic BP of below 90, pulse over 100 or below 60, and anion gap over 60. If individual exhibits any of these signs, resuscitation and the treatment should be started without delay, and intensive monitoring regimen should put in place. Depending on the local circumstances, individuals who fulfill the criteria for severity or who require intensive monitoring should be reviewed by a consultant physician and considered for the swift referral to the level 2 HDU environment, or if the patient has failed to improve after initial resuscitation measures. It may also be necessary to consider surgical cause for the deterioration. If surgery is required, there will be need to be urgent senior multidisciplinary discussion on the optimum time to operate. Now about intravenous access and initial investigation. Rapid airway breathing circulation stabilization should be established. Then large bore IV cannula, commence IV fluid replacement. The proper clinical assessment should be done, including respiratory rate, temperature, blood pressure, pulse, and the oxygen saturation. GCA scale should be recorded. A drowsy individual in the context of decay is seriously concerning, and the patient require critical care assessment. Consider NG tube with the airway protection to prevent aspiration. Then full clinical examination. The investigation includes blood ketone, capillary blood glucose, venous plasma glucose, urea and electrolyte, venous blood gases, and full blood count. And also consider sending blood cultures, ECG, chest radiograph if clinically indicated, urine analysis, culture, continuous cardiac monitoring, continuous pulse oximeter. Consider precipitating causes and treat appropriately. Establish usual medication for diabetes, pregnancy test in female of childbearing age, and COVID-19 test. Then care, immediate management upon diagnosis, that is care that we have to provide within initial 0 to 60 minutes. Commence IV 0.9% sodium chloride solution. Commence fixed ratio insulin infusion, but only after fluid therapy has been commenced. Establish monitoring regimen appropriate for person with diabetes. Generally, hourly blood glucose and hourly ketone measurement with at least 2 hours serum and blood potassium and bicarbonate for at least for 6 hours. Clinical and biochemical assessment of an individual involve a diabetes specialist team at earliest possible stage. Consider referral to the level 2 and HD environment if criteria for severity are met and if facilitate for intensive monitoring are unavailable. Then about restoration of the circulating volume, assess severity of dehydration using pulse and blood pressure as a guide. 90 mmHg may be used as a measure of dehydration, but take age, gender, and commitment medication into account. Uh, uh, then systolic blood pressure on admission below 90 mmHg hypotension is likely due to low circulating volume, but consider other causes such as heart failure and sepsis. So in this situation, give 500 ml of 0.9% sodium chloride solution over 10 to 15 minutes. If SBP remains 90 mmHg, remains below 90 mmHg, this may be repeated while awaiting senior input. In practice, many individuals require between 500 to 1000 ml given rapid. If there has been no clinical improvement, reconsider the other causes of hypotension and seek an immediate senior assessment. Consider involving ITU and critical care team. Once the systolic blood pressure is above 90 mmHg, follow fluid replacement as follows. So 0.9% of sodium chloride of 1 liter, that is 1000 over first hour, then 1000 over next 2 hours, then 1000 over next 2 hours, 1000, then after that 1000 ml over next 4 hours. Uh, Again, we have to repeat it for 1000 ml over next 4 hours, and then after stabilization, give 1000 ml over next 6 hours. So reassessment of the cardiovascular status at 12 hours is mandatory and further fluid may be required. Potassium chloride may be required if more than 1 liter of the sodium chloride has been given already to resuscitate those who are hypotensive. Exercise caution in the following group. Young people aged 18 to 25 years, elderly, pregnant, heart or kidney failure, and other serious comorbidities. About potassium replacement, hyperkalemia are life-threatening condition and are common in decay. So serum potassium is often high on admission but falls precipitously upon treatment with the insulin. So regular monitoring is mandatory. So if potassium level in first 24 hour is over 5.5, then we don't need, then there is no need of replacing any potassium. If it is between 3.5 to 5.5, then the potassium 40 MEQ of the potassium should be replaced. And if it is below 2.5, then senior review as additional potassium need to be given. Then commence fixed rate intravenous insulin infusion. If person is unable to state their weight or if it is not available, estimate it in kilogram. If it is a pregnant female, use her present weight and call for immediate additional senior obstetric help. Start continuous fixed ratio insulin infusion via insulin pump. This is made up of 50 units of human soluble insulin uh, that is made up to 50 ml with 0.9% sodium chloride solution. Ideally, this should be provided as ready-made solution. Infuse at a fixed rate of zero point 0.1 unit per kg per hour. Only give bolus dose of intramuscular insulin, that is zero point 0.1 unit per kg, if there is a delay in setting up fixed ratio in intravenous insulin infusion. If the individual normally takes a long-acting basal insulin, continue this at a usual dose and usual time. That is long-acting insulin like glargine, deglutec, determer, and human isofen insulin. Insulin may be infused in the same line as an intravenous replacement fluid, provided that Y connector with one way and antisiphon valve is used and large bore cannula have been placed. However, two large bore intravenous catheters are advised. Then after providing this initial care, then further management, which we have to done from 60 minutes to 6 hours. That is, clear the blood of ketone and suppress the ketogenesis. Achieve the rate of fall of ketone at least 0.5 mmol per liter per hour. In the absence of ketone measurement, bicarbonate should rise by 3 mmol per liter per hour and blood glucose should fall by 3 mmol per liter per hour. Maintain serum potassium in the normal range. Avoid hypoglycemia. Consider referral to the level 2 environment if criteria for severity are met after initial resuscitation and if facilities for intensive care monitoring are unavailable. Then action 1 is reassess and monitoring vital sign. So during this time, individual should be reviewed hourly, initially to ensure that adequate process is being made in reducing ketone and glucose concentration. Consider urinary catheter if person is incontinent or anuric. Consider nasogastric tube insertion if the patient is obtunded and persistently vomiting. If oxygen saturation falls, then perform ABG measurement and request repeat chest radiograph. Regular observations and early warning score charting as appropriate. Regular assessment of the GCA score. If this drops, then urgent brain imaging should be considered. Maintain accurate fluid bolus balance chart and maintain urine output should be no less than 0.5 ml per kg per hour. Continuous cardiac monitoring in those with severe decay. Give prophylactic low molecular weight heparin. Then action 2 is review metabolic parameter. Measure blood ketone and capillary glucose hourly. The hourly glucose reading should be recorded directly into hospital pathology system. Where this is not possible, the result should be recorded in the notes. Review the response to fixed ratio insulin infusion hourly by calculating the rate of change of ketone level fall. Then assess the resolution of ketoacidosis. If blood ketone measurement is available and blood ketones are not falling at the rate of at least 0.5 mol per liter per hour, call prescribing clinician to increase the infusion rate by 1 unit per hour, increment hourly until ketones are falling at the target rate. If ketone measurement is not available, use venous bicarbonate. If bicarbonate is not rising at the rate of 3 mmol per liter per hour, then we need to increase the insulin infusion rate by 1 unit per hour hourly until the bicarbonate rising at this rate. Then alternatively use plasma glucose. If the glucose is not falling by at least 3, then we need to again increase the insulin infusion rate by 1 unit per hour in increments hourly until the glucose falls at this rate. Glucose level is not accurate indicator of resolution of acidosis in ketosis, so the acidosis resolution should be verified by venous gas analysis. If ketones and glucose are not falling as expected, always check the insulin infusion pump is working or connected and that correct insulin residual volume is present. Measure the response for pH, bicarbonate, and potassium at 60 minutes, 2 hours, and 2 hours thereafter. If potassium is outside the reference range, assess the appropriateness of the potassium replacement and check it hourly. If it remains abnormal after further hours, seek immediate senior medical advice. Continue the fixed ratio insulin infusion until ketone measurement is less than 6 less than 0.6 mmol per liter, venous pH over 7.3 and venous bicarbonate over 80. Do not rely on the urinary ketone clearance to indicate resolution of the decay because there will still be present when decay has resolved. If the glucose falls below 14, commence 10% glucose given at 125 ml per hour alongside the zero point 0.9 sodium chloride solution. In addition, consider reducing the rate of intravenous insulin infusion to 0.05 unit per kg per hour. Monitor and replace potassium because it may fall rapidly. The intravenous insulin and dextrose infusion should be infused using Y connector. Then action 3 is identify and treat precipitating factor. Action 4 is those precipitating those presenting with the newly diagnosed type 1 diabetes should be given long-acting basal insulin like glargine, determide, or degludec on human NPH insulin depending on the local policy at a dose of 0.25 unit per kg subcutaneously once daily to mitigate against rebound ketosis when they are taken off the fixed ratio insulin infusion. Then management the line that we should follow in next 6 to 12 hours is the aim within this time period is to ensure that clinical and biochemical parameters are improving at correct. So continue IV insulin, continue insulin administration, assess for the complication of the treatment like fluid overload, cerebral edema, continue to treat precipitating factor as necessary. Avoid hypoglycemia. Consider referral to the level 2 environment if criteria for severity are met and despite the adequate treatment, or if there is deterioration in the clinical status, or if facilities for intensive monitoring are unavailable. Reassess the individual and monitor vital sign. If person is not improving as expected, then seek early senior advice. Regular assessment of the GCS. If this drop, then urgent brain imaging. Ensure referral has been made to specialist diabetes team. Consider a referral to the level 2 environment if criteria for severity are met and if facilities for intensive monitoring are unavailable. Review biochemical and the metabolic parameters. At 6 hours, check the venous pH, bicarbonate, and potassium, as well as blood ketone and glucose. Resolution of the decay is defined as ketone less than 0.6 mmol per liter and venous pH over 7.3. Then management in 12 to 24 hours. Aim should be ensure that clinical and biochemical parameters are improving and have normalized. Continue IV fluid if the patient is not eating and drinking. If the person is not eating and drinking, there is no ketonemia. Move to the this insulin infusion as per local guideline. Variable rate insulin infusion as per local guideline or following the JBDS guideline. Reassess for the complication of the treatment like fluid over. Regular assessment of the GCS score. If this drops, then urgent brain imaging should be considered. Continue to treat any precipitating factor as necessary. Transfer to the subcutaneous insulin if the individual is eating and drinking normally. Ensure that subcutaneous insulin is started before the IV insulin is discontinued. Ideally, give subcutaneous fast-acting insulin at a meal and discontinue IV insulin 30 to 60 minutes later. Conversion to the subcutaneous insulin. The person with the diabetes should be converted to appropriate subcutaneous regimen when biochemically stable and they are ready and able to eat. Conversion to the subcutaneous insulin is ideally managed by diabetes specialist team. If the person with the diabetes is newly diagnosed, it is essential they are seen by a member of specialist team prior to the discharge. Thank you guys.